Hi, everybody. You guys have come a long way. We're on section 9 now. I hope you guys have taken some breaks, which you probably have had to since there are so many sections of diabetes. So now we're going to talk about pharmacologic approaches to treating high blood sugars. First of all, this is talking about type 1 only. Remember, type 1 is complete beta cell destruction. So remember, these people have multiple daily injections, and usually they'll have a pump, and they have prandial and basal insulin. So they'll have the long-acting insulin as well as the rapid-acting insulin. Seems to be more of the mainstay now, where you won't see as many patients that have Humulin N or even regular. It's more the Lantus, Levemir, and the rapid acting Humalog or Novolog. So most individuals with type 1 should use the rapid acting insulin to reduce hypoglycemia risk. And considering educating individuals with type 1 on matching prandial insulin doses to carbohydrate intake, pre-meal blood glucose levels, and anticipated physical activity. So these people are at an increased risk for hypoglycemia. Exercise will definitely bring blood sugar down. So these people need to always have snacks on them, be prepared, and counting carbs and figuring out how much insulin they need to how much carbs or how many carbs they're having to eat. Now, there are people that do follow a low-carb diet. That just means their insulin needs probably are not going to be as great as those that eat more carbohydrates. But it definitely can be done, since now we have a new hype of the keto diet out there that patients are actually following that. And please don't get that mixed up with ketoacidosis. It's completely different. It's pathophysiologically different and what it's doing in your body. Those individuals with type 1 diabetes who have been successfully using continuous insulin should just have it continued after age 65. Again, if they're doing well and they're of sound mind, then yes, it should be continued. But remember, everything's always tailored to the patient. As far as insulin injection, I know you guys know how to teach insulin injections techniques. You guys are nurses, but always rotating the sites. Make sure no IM delivery. It's all sub-Q and the shorter needles. All right, so how do medications work for diabetes? Now we're going to go on to type 2. We do know type 2 and are also on insulin at some time. Not everybody does. Depends on how controlled and how destroyed their beta cell function's been. But I thought this was a nice picture to show the different types of therapies that are out there and where it's working. So, for example, the newer ones, sitagliptin, linagliptin, saxagliptin. These are your GLP-1s that you'll hear about, like Victoza and Byetta. These help the pancreas make more insulin and reduce the amount of glucose made by the liver. So they work with the pancreas and also the liver. So just the pancreas that's affected, that's your sulfonylureas, which is your glimepiride, glipizide, and repaglinide, all of these. Now, the most common ones that are prescribed now are glimepiride. Sometimes you'll see glipizide, but not as much anymore. And I really have not seen the other three there, but it stimulates the pancreas. And if you go down to the intestines, and these are medications that really aren't prescribed anymore, but they help break down carbohydrates and lower your blood glucose levels. I'm not saying it's not an option. There's just different ones and better ones out there that people use those for choices instead. And kidneys, these are the SGLT2 inhibitors. These are your Invokana, and I forgot what the other name is, but these are the generic names. And those prevent the kidneys from holding onto the glucose. And so that's when these people have side effects of yeast infections and UTIs. And liver, fat, tissues, and muscles. This is your metformin. This is your TZDs, which is your rosoglitazone, and pioglitazone, your Actos and Avandia. So these lower blood glucose by reducing the amount of glucose made by the liver and increasing sensitivity to insulin of fat, liver, and muscle cells. So these are really good for insulin resistance patients, which is a lot of type 2 diabetics. So just some little tidbits about the pharmacological therapy. Metformin's always still number one and should be on it as long as possible, as long as they don't have any contraindications. But if they're on metformin, there is a known fact that they can have B12 deficiency. They're not able to absorb it as well. So you should always check B12 levels approximately every 6 months or so to just make sure that their B12 levels are okay, and treat them if they do have B12 deficiency with B12. You can give them oral B12 and just check it. And if they're not responding to that, then you can go ahead and do injectable B12 injections. But usually, if they take an extra orally, they're usually able to absorb it if they're taking bigger doses. And this one also says that it basically gives us permission to introduce insulin early if we do see evidence of weight loss, or if they're really hyperglycemic, such as an A1C greater than 10, or we see their glucose levels of greater than 300. So that's in level E, so expert opinion is saying that. And consider a dual therapy, which I'll show you the algorithm in patients with newly diagnosed type 2 diabetes who have an A1C greater or equal to 1.5 above their target. So remember when we talked about the slides of what patients' target should be, and it gives us providers some leeway as to how we're going to determine what their target should be. Is it going to be 6.5 or less, or are we going to have them more around 7.5 or 8, again, depending on the person. And it's always patient-centered because many of these people can have comorbidities, heart disease, heart failure, kidney disease. One thing that's important is cost. Whenever we prescribe, we're really looking at what the insurance is, which is just a reality, risk for side effects, and what the patient prefers. So it's always a good conversation with patients. So this is really good knowledge here when you're deciding what to prescribe the patient. So when you have a type 2 diabetic who has atherosclerotic or cardiovascular disease, so someone who's had an MI, someone who's had stents before, SGLT2s or the GLP-1s they have demonstrated some cardiovascular disease benefits. So they're recommended as part of the regimen. So again, if they're on metformin and they're just not to goal, that would be one of those would be a good add-on therapy. Also, and that's a recommendation A. So that's, we have some really good studies to show that. And those with cardiovascular disease at high risk of heart failure, SGLT2s are preferred. So, remember, we're not going to give the the TZDs, like your Actos and Avandia, because those are contraindicated in heart failure. It's shown to worsen heart failure. For patients with type 2 and chronic kidney disease, again, it's recommending the SGLT2 or a GLP-1. It's shown to reduce chronic kidney disease progression and cardiovascular events. So these are just the different studies that have been done and the recommendations. In most patients who need the greater glucose lowering effect of an injectable medication, then you can switch to, or actually it's saying a GLP-1 is preferred over insulin. So you should always try to do this, the GLP-1s, first before going to insulin, unless, again, as it says on the other slide, if their A1C is very high and their fasting glucose is in the 300s, or even non-fasting glucose is in the 300s. A lot of people ask, well, will they be on insulin permanently? Not necessarily. Sometimes you just need to get that down, start metformin, and then start switching them over to the oral medications. All right. And we should always reevaluate at regular intervals, every 3 to 6 months. So if everyone is stable on their medications, every 6 months is guidelines. If they're not, then they should follow up every 3 months and earlier if needed. I know this table is hard to see, which is why I linked the article that Dr. Parvey should have uploaded, and it's a little bit easier to read. I'm not going to go through each of these, but just so you know, it gives all of the classes below, or on the left-hand column, and on the top talks about efficacy, hyperglycemia, weight change, any cardiovascular effects, which ones are cheaper, which ones are more expensive, if there's any renal effects, and any additional information. So just to hit key points, metformin, you have to really watch their creatinine levels. So if their GFR is less than 30, then it's really contraindicated. And sometimes if we see their creatinine going up towards 1.3, 1.4, we will end up taking them off metformin at that point. Again, we heard about the SGLT2 inhibitors, how they are really good and shown some evidence of decreasing cardiovascular and kidney disease. So that's a good choice, but they can cost a lot of money. So it just depends on their insurance. GLP-1, same thing. They can cost a lot of money, although it just depends on the insurance. And even state Medicaid covers Byetta, for example. So don't give up on them. And also, people on state Medicaid, there should be a list that comes out. I think they review their stuff every month, so their formulary changes quite often. But I used to keep the formulary with me, so I just look on the list. My medical assistant would always make sure that list was updated. It really helps me with choosing the best medication that I can. And as we know, the TZDs with congestive heart failure, and I tell patients that they can have some leg swelling with that. If they do, they need to really follow up and let somebody know. Sulfonylureas, the main thing that stands out is hypoglycemic risk, because remember, it's stimulating the pancreas, the beta cells, to produce insulin. So if you're not eating very well, you are at higher risk for hypoglycemia. But again, these are not as expensive. And the least hypoglycemic drug in that class is glimepiride. So it seems to be the safest out of all the research that's been done. And then we have insulin. All right, so this is a nice little graph, which you have to really take some time to study it a little bit. So I suggest you do that. But if we look at first line, metformin and lifestyle changes. First you determine their target. All right, you put them on metformin, and you talk about lifestyle changes. In the meantime, while you're doing that, you're determining, do they have any other comorbidities? Do they have cardiovascular disease or kidney disease, or don't they? So that's going to help guide you on this. So if they do, this is a really nice newer table that's come out, or algorithm, I should say. So if they do, if they really have had a history of an MI in the past, or some kind of heart disease, or even a significant family history, you may go down this line here and put them on, a GLP-1, which would be your Byetta or your Victoza. These are injectables. Or you can pick the SGLT2s, which is more or less your Invokana, Farxiga, and go on from there. So if hemoglobin A1C is above the target, then you can add this. It says either or you can consider adding the other class, or you can add these. So again, this is where once you become more experienced, you will appreciate all of this, because you have choices. Starting out as a new NP, sometimes it can be a little intimidating because you want to make sure you're doing the right thing. Is it okay if I put them on this? You will get through this, I promise. But I think even these 2019 guidelines are better, because it even gives us some more. Like before, it never really said this cardiovascular disease. This never existed. It was up to us to try to determine out of all these drugs. So these are much better. So if they don't have heart disease, let's go over here. But they really are obese. We have to help them lose some weight. The GLP-1s have some good efficacy for weight loss, as well as the SGLT2s. So you think about that. If cost is a major issue, sulfonylureas and your TZDs. And if not, you add the other one. So it tells you exactly what to do. And what this is basically the left side of this here. So the next slides are just going through them more in depth, and it'll tell you exactly what to do. It's just more close up so you can read them. And uh, so these are patients, remember, they're on metformin already, and now you're adding a medication to it. Now, another choice is you don't always have to start them on insulin. You can have an A1C of 12, and I've put people on metformin, and then I've added perhaps a GLP-1 to it. They could be obese, so that's efficacious. They can have a history of hypertension, which isn't necessarily cardiovascular disease, but I still will put them on that because then they have possibly a dual effect with that. All right. And then this is the same thing here. This is the second part, or the second whole part of it. So if a compelling need to minimize hypoglycemia, that is when you're not going to deal with medications that are directly used as an insulin sensitizer like the sulfonylureas are. So this is where you use the DPP-4 inhibitors, the GLP-1s, DPP-4 inhibitors, Januvia, that's the first one that was out. It brings the A1C down about 0.4. So again, when you're picking these medications, you kind of have to look at how much it's going to bring the A1C down. And usually the charts show that. So let me just see if this will show that. This one does not. So I'll have to see if I can find one that shows, because that's really helpful. I just know in the back of my head, like a sulfonylurea can bring it down 1 to 1.5%, the A1C. Same with the TZDs. You can get the DPP-4s are anywhere from like 0.6 to 1 percentage drop. GLP-1s can be anywhere from 1 to 1.5. Same with the SGLT2s. Those are just off the top of my head. And these are the actual doses that you can put patients on. So I'll just mention a couple things. With the metformin, always start the patients on extended release. One of the most common side effects is GI issues such as diarrhea, stomach aches, nausea, gas passing. So the extended release will help lessen that. And I always tell patients that you may have some side effects in the beginning, some diarrhea, but most of the time that ends up going away. So you just have to get used to it, and you just start them at 500 milligrams twice a day, extended release. And usually people are fine. And then you go up to, so then at that point they're on 1,000. And then what you can do is increase it to 1,000 twice a day. Then they're on the max dose. You see over here, the max dose is 2,000 milligrams. So GI upset, put them on extended release. Sometimes their insurance won't cover it. As you can see, it's much less expensive for the immediate release, although it can cause more significant GI effects, and they'd rather not take it then. Here's the sulfonylureas, and these are the doses. Again, use your whatever app you use, Appraoches, MPR, Micromedics, whatever you use to get your drug dosaging. So, and then you just go right down the line here. So this one talks about different targets and when to titrate to add insulin. So, okay, if you see this long thing, it's hard to read. I'm going to go to this one. This is the top part of it. So let's just say this person's on metformin and they're on a TZD and they're on a GLP-1 and it's not doing, actually on their TZD and metformin, and nothing's happening. So, and their A1C is still a 9. So you can go, it says over here, you can consider doing some insulin. You can do a GLP-1 plus a basal insulin, or the prandial basal insulin, or, and this is if you're about like 2% above target. So if your A1C is 9 and you need to get to 7, then you could just add insulin to that. So this just gives an option. Or you consider just starting the GLP-1, which is your Victoza or your Byetta, or Bydureon is the other one. And oops, it tells you how to do it. Initiate starting dose. It varies across classes, so it just depends. But there's a lower dose, and then you increase it to the higher dose after so many weeks. And then you titrate it. And so that's the GLP-1. But it does say to consider insulin as first injectable if it's very high, if your A1C is around 11%. If you, again, have polyuria, polydipsia, if it's noticing that you're just having symptoms and you're not getting to target, maybe you want to not add the GLP-1, maybe you want to add insulin to the regimen, but you can add the GLP-1 and the insulin, so don't forget that. You can combine those two. If I were to add insulin, though, I want to make sure that I stop my, you can stay on metformin, but I would definitely, if they were on a sulfonylurea or any one that directly works on the pancreas, you want to cut that in half at least, because now they're at hypoglycemic risk. So here it tells you over here how to initiate for the basal insulin. So that's your Lantus or Levemir. You start 10 units a day, or you can calculate the 0.1 to 0.2 units per day. I've seen it all over the board, and I usually do the kilogram because I feel like everybody's different, and so I use the 0.1 to 0.2, and I just look to see what their blood sugars have been. If they're writing in the 400s, I'll probably go towards the 0.2. And it tells you self-titration is more effective. So if this person's reliable, you have them self-titrate it. So every 3 days or so, you have them increase it. So it says here to increase 2 units every 3 days to reach their fasting plasma glucose target without hypoglycemia. All right. So it tells you everything on what to do here about how you're going to initiate things. So if you're already on a GLP-1, not appropriate or insulin preferred, then you go here as for insulin. If you are, let's go over here. For patients on GLP-1 and basal insulin, perhaps you want to consider these other types of insulins are longer acting insulins. If you're on the GLP-1, you can add these 10 to 16 dose steps, which I'll get into in a little bit. And then you titrate. All right, and this just goes right down the line. So now, how are you going to add prandials? So these are people that should be on rapid acting that you're adding. One good piece of advice to avoid hypoglycemia and avoid overwhelmingness in the beginning of these patients being on insulin is to ask them what their biggest meal is of the day and just start with one meal of the day. So they're taking the basal already, and now you're going to add the before meals. All right. I'm going to move on to the next slide. And again, this talks about the different types of insulin here. So if you see down here, this is the glargine and the Declicted, and these come in pre-filled pens. They're pre-mixed insulin, which is GLP-1 and insulin in it. They're very expensive as far as what I'm seeing, and I've never prescribed them. I always done it separate just because the population that I see, that the insurance won't cover it. But that's, if you look back and we were talking about this over here, that's what these are. They're pre-mixed. So if you're on a basal insulin, they're suggesting, well, you could go ahead and just do the combination. All right, and I just want to show you one more thing on here. I know this one is a little bit longer, but I do have the ACE guidelines too, because I think it's important that you know the ACE guidelines and the ADA guidelines. And I'm just doing this as an overall type 2 diabetes management algorithm. So I'm not going to go over these because this is the same thing as the ADA. These are the same thing as the ADA on what they prefer. But they give some nice algorithms and how to strategize treatment for them. So it goes to nutrition, physical activity, sleep, behavioral support, and smoking cessation. And then these are for if you're obese. And so if you have no complications or complications, it tells you what to do. Lifestyle therapy, and then medical therapy down here. Phentermine, orlistat, it tells you different medications for them to try to take. And if you're in the severe stage, it goes all the way down. So if you see here, it starts here. If they have no complications, then it's really just counseling, and they really need a good plan going. Possibly they could go down to medications. All right. And then this starts going to here, and then if it's more severe, you go down to this more of a surgical approach. Pre-diabetes algorithm, lifestyle therapy, treat risk factors. So you're going to think about high cholesterol and hypertension, weight loss therapies. You're going to treat the hyperglycemia. So are you going to put them on metformin, low risk medications here? Tells you to consider with caution, but you can put patients on these. Because if you have prediabetes, you have insulin resistance. So you want to give them something that's going to help with that insulin resistance. And then this tells you how to treat the dyslipidemia and hypertension. So we know hypertension is really good for the kidneys with diabetes to add an ACE inhibitor or an ARB if they're not tolerating an ACE. But remember, that's dual therapy if you cannot get their blood pressure down. Where at this point, the ACE guidelines are 130 over 80, should be less than that. So if it's over that, then you do the ACE or ARB. If it's over 150 over 100, then consider adding a calcium channel blocker, beta, or thiazide diuretic. If not at goal, you add the calcium, beta, or thiazide. If not at goal in 2 to 3 months, add the next group. If not at goal again, then you add the next group. So remember, it's really important to achieve target blood pressure. Your heart's a muscle. It can be overworked, and if it's overworked over a long period of years, that's when you have cardiomyopathy and heart failure as you get older. I tell my patients that it seems to kind of scare them into making sure they take their blood pressure pills. Also, assess their atherosclerotic cardiovascular disease risk. Talks about statins, and what I recommend is going to the atherosclerotic cardiovascular disease risk calculator plus. Don't use the other one, use the plus, because that is actually now more enhanced. I just went to a webinar about that, and that's the one that we should be using and helps determine what they should have. And if needed, they need to have an NMR lipoprofile, which you see down here, ApoB, LDLP. That's how you get those to determine, do you have the dents that are likely to clog your arteries, or do you have the large puffy ones that are going to bounce around and not start any issues. This is set up a little bit different, although very much the same. A1C, it's individualized goals. A1C greater than 6.5. So lifestyle therapy, A1C is less than metformin, and you go down the line. Greater, you start with dual therapy, possibly triple therapy. It just depends. So I think it's important that you study this. You can always send me an email if you're not understanding. This is all for starting insulin. I think the ACE guidelines to me are easier to read. But again, you can do whatever you want as far as that. Now, if you see here less than 8, it gives you more of a guide, 0.1 to 0.2. A1C greater than 8, 0.2. You can go up to 0.3 units per kilogram to start the insulin. You always start basal first. Then you intensify it by adding the mealtime insulin. They can start at 1 and then go to 3 meals a day eventually if things are not going down. And these are basically what's in the other one, but it tells you all like the different side effects here. It's just it's flipped a little bit. And that is it on this slide set.